Thanks, LIGHTMED, for allowing me to speak about one of my passions, which is glaucoma laser. Today's talk will be multi-approach for the treatment of glaucoma with SLT, um, SPLT, and YAG LPI. As we said, I'm near Shoham-Hazon. I'm the glaucoma and cataract and advanced anterior segment surgeon in one of the Atlantic provinces, east coast of Canada. So these are my financial disclosures. So this is my laser machine. So I have the LIGHTMED Tri-Laser LIGHTLas, which has a YAG SLT and the 532 green or argon laser attachment. We can see on the left, we have the SLT YAG vitreolysis tower, and on the right on this setup, we have the 532 green laser. Something that I really appreciate just thinking about all the possible wires you have is the actual wireless foot switch, which is seamless. It works beautifully for our longer ophthalmologists, shorter ophthalmologists. So it's very easy to maneuver and kind of find the patient's legs in between and manage well. These are actually images of me. I was actually the first patient on my laser system. I'm a former high myope, so I had some retinal thinning, and our senior ophthalmologist treated me with this laser. And something that was remarkable initially when he's an ophthalmologist with 27 years worth of experience, and when he just looked through the oculars, I think his first words were, wow, since the optics of this Tri-Laser LIGHTMED were so superior to anything that he had used in the past. So that's just a bit of a plug-in of why we love this laser so much. So the agenda for today, we'll talk about the glaucoma treatment paradigm. We'll talk about open angle glaucoma, angle closure, some history about laser trabeculoplasty. We'll talk about selective laser trabeculoplasty with a light study, pearls about SLT and subthreshold pulse laser trabeculoplasty, the benefits, and some case studies. So this is a very nice publication or review article out of Canada here by Paul Harasimovich and his colleagues discussing the different medical management of glaucoma in the 21st century. So initially, when we talk about glaucoma in general, we have to classify open angle glaucoma versus angle closure. When we discuss open angle glaucoma, we've got primary open angle, normal tension glaucoma, and secondary open angle glaucoma, and the secondary glaucomas are in the table below. When we talk about open angle glaucoma, we have to discuss staging, of course. So we've got glaucoma suspects, and these criteria apply to them. Early glaucoma, which is characteristic of early glaucomatous optic neuropathy or disc damage with mild visual field deficits. Moderate glaucoma, already larger cupping with moderate visual field deficits with a mean deviation between -6 and 12. And the advanced cases with larger cupping, involvement of 10 degrees fixation in visual field, or MD of worse than -12 decibels. When characterizing target IOPs, we have to consider, again, the stage of glaucoma and where we want the patient to wind up with their targets. With glaucoma suspects, we're more allowing pressures in the lower 20s. In early to mild glaucoma, our permissible pressures would be in the upper teens. Moderate glaucoma, we kind of want them to be around the mid-teens, and the advanced glaucoma, we would want them to be lower in the lower teens. When we talk about angle closure, we have primary angle closure suspects for the primary angle closure, which means over 180 degrees of appositionally closed angle. When we talk about primary angle closure, that's already when pressure is above 21, plus the before mentioned parameters. And when we talk about PAX-G or primary angle closure glaucoma, we now have the narrowing of the angles, the elevated pressure, as well as glaucomatous optic neuropathy with visual field damage. So we'll start with a case for this topical treatment paradigm. We're talking about a 64-year-old patient, IOPs on presentation 24 and 25, right and left eye, average central corneal thickness. The cup to disc ratio is about 0.7, 0.75. Visual fields are normal. The RNFL and ganglion cell layer on OCT are maybe just inferior loss. So we would characterize this patient as having ocular hypertension or maybe mild or early open-angle glaucoma. And we would expect, if we start them on a prostaglandin analogous monotherapy, to reach a target or IOP of around 18 or 19. However, in recent years, we now have the LIGHT trial, which also shows us that starting therapy with selective laser trabeculoplasty or subthreshold pulse laser trabeculoplasty might reach the same result in terms of about 30% reduction in IOP and reach the same amount of pressure lowering. The next case is a 54-year-old patient, IOPs on presentation around 18 or 19. Again, average-ish central corneal thickness with a cup to disc ratio of about 0.8, 0.85 on the left. Visual fields show moderate disease with inferior and superior loss of RNFL and ganglion cell complex or layer. And we'll characterize this patient as having moderate open-angle glaucoma. And this patient presented already on a fixed combination prostaglandin analog, or perhaps a prostaglandin and a fixed combination beta blocker or carbonic anhydrase. And instead of adding another drop or a second bottle to this patient by adding either selective laser trabeculoplasty, SLT, or subthreshold pulse laser trabeculoplasty, we can reach mid-teens of IOP, and that would be the target for this moderate open-angle glaucoma patient. So our traditional treatment paradigm, going from left to right, was starting topical therapy, and after exhausting maximal tolerated medical therapy, we would go to laser trabeculoplasty. And the next stage would be a trabeculectomy followed by a tube shunt. In recent years, interventional glaucoma has been coined as having earlier interventions in the treatment paradigm. And topical therapy can actually be as the first line. However, laser trabeculoplasty can also be as first-line therapy, followed by, if one chooses maximal tolerated medical therapy or non-incisional minimally invasive glaucoma therapy, such as transscleral laser therapy or cyclophotocoagulation, or perhaps even minimally invasive glaucoma surgery, and following in the right, more invasive procedures. As innovation progresses, we have, if we look on the right, we've got the iStent, which started as the first generation, then second generation in the middle, and then the wider third generation. On the left upper part of the slide, we used to have Zen 45 with a 45 micron lumen. Now we've got a larger lumen. And just like, for example, in cars, we're now moving from internal combustion engines to electric vehicles. We have in laser trabeculoplasty, we used to do argon laser trabeculoplasty or ALT. We have since the 2000s SLT, but also we now have micropulse or subthreshold pulse laser trabeculoplasty. So my treatment paradigm we're going to talk about as well In the past, again, we used ALT, now we use more SLT, and I do incorporate the subthreshold laser trabeculoplasty as well in my treatment paradigm. And something I actually follow is the mantra below. And I always say the most dangerous phrase in the language is we've always done it this way. And practicing glaucoma, we currently can't say that this is how we've always done it because the technology is advancing and progressing so much, and we have to embrace it. So I'll talk about the LIGHT trial, which is selective laser trabeculoplasty versus eye drops for first-line treatment of ocular hypertension and glaucoma. This was a multi-center randomized control trial whereby selective laser trabeculoplasty we know provides superior intraocular pressure stability to drops at a lower cost and allows almost 3/4 of the patient in the trial, 74%, to be successfully controlled without drops for at least 3 years after having primary SLT. The groups had similar endpoints in terms of visual acuity, in terms of intraocular pressure, and visual field loss mean deviation. Some of the findings of the LIGHT trial were that basically the study compared SLT to a prostaglandin analog as first-line therapy. And what we've seen is that SLT at 6 years showed a drop-free patients of 70% of the patients were drop-free and better glaucoma severity score, fewer eyes in the laser group progressed rather than the drop group, and that was statistically significant, and fewer interventions or cataract surgeries required in the laser group versus the glaucoma drop group. So this is a study which shows us preservative exposure and surgical outcomes in glaucoma patients. This is the peso study by Katie Burt out of Toronto, Ontario, Canada. This is a study which basically showed that increased preoperative exposure to ophthalmic solutions preserved with benzalkonium chloride, BAK, is a risk factor for earlier surgical failure, independent of the number of medications used. And this study actually extends earlier findings of potential adverse effects of ophthalmic preservative on surgical outcome to modern pharmacopoeia used in medical management of glaucoma. So basically, this study showed us that using more drops for longer time with a greater exposure to preservative actually increased surgical failure of glaucoma surgery. This is a study comparing SLT versus medication, again, out of Canada by the famous Cindy Hutnick of Ontario as well. And this is a study showing projected cost comparison of selective laser trabeculoplasty versus glaucoma medication in the Ontario Health Insurance Plan. And basically what this study showed is that SLT as primary therapy as a per patient level offers a modest potential cost savings over primary medical therapy in the management of open-angle glaucoma for patients in Ontario over 65 years of age. So basically, this table shows us the cumulative 6-year cost comparison of SLT versus drops. And we see that from the second year, we see a cost savings to the system and the patient when using laser trabeculoplasty over actually using topical medical therapy, so drops. So my treatment paradigms is as follows. Again, going from left to right, we see that when I have a patient with primary open-angle glaucoma or ocular hypertension that I deem that requires a lower target IOP, I do start with laser trabeculoplasty. Of course, I offer the different options. I say There's an option of starting with drops. There's an option of starting with laser therapy. The laser therapy, I also cite some of the light trial results to show the benefit of laser over drops. You must always discuss the risks, benefits, and alternatives to each option, and then let the patient decide if they prefer to have laser trabeculoplasty versus topical therapy. So we'll talk a little bit about history of laser trabeculoplasty. So the history of laser trabeculoplasty basically started with the argon laser trabeculoplasty, which was first described in 1974, and thereafter a study by in 1979 by Weiss and Witters had actual pilot study. And in 1990, the National Eye Institute founded a large randomized control trial called the Glaucoma laser trial, which randomized patients to receiving timolol versus 360 degrees of ALT. And they concluded, and the conclusion was that the laser trabeculoplasty was as efficacious as medical therapy for treating primary open-angle glaucoma. So again, back to history, 1979, this was the study by Weiss and Witter, which showed that argon laser applied 360 degrees over the trabecular meshwork. It was a study over that spanned 56 patients. These were the laser parameters. 41 eyes were controlled with the laser, 27 required 27 eyes required medical therapy, and 6 eyes actually required surgical therapy. Mean IOP lowering from 8 millimeters up to 18 months. So, sorry, 10 millimeters up to 18 months. No angle scarring was seen, no serious complications of this laser trabeculoplasty. And the presumed mechanism of action for this laser was actually increased trabecular meshwork tension. And the conclusion was that ALT or argon laser trabeculoplasty appears to, ALT appears to be an effective alternative to filtration surgery in phakic eyes. So the glaucoma laser trial was a multi-center randomized control trial with 271 patients. This was a safety and efficacy trial of ALT compared to timolol. Newly diagnosed bilateral primary open-angle glaucoma patient, one eye assigned for topical therapy, the fellow eye assigned to initial argon laser trabeculoplasty with the following protocol on the right, and evaluated immediate effect of ALT and long-term effect, and the need for medication, visual field deterioration, optic nerve deterioration, visual acuity, and adverse reactions were monitored. So, sorry for 1 second. I'll just take a cough drop. I apologize for that. Sorry for a sec. So each patient had one eye randomly assigned to ALT, which was the laser first eye, the other eye assigned to timolol, the medication first eye. Throughout 2 years of follow-up, what we saw is that laser first eye had lower mean IOP than the medication first. And a fewer laser first eye, then the medication required simultaneous prescription of 2 or more medication to control IOP, and this was statistically significant. After 2 years, 44% of the laser first were controlled by ALT, and there were no major differences between the 2 treatment approaches with respect to change in vision and visual field after 2 years. So this was, again, a supportive study for laser as a first option, and this was already early in the 1990s. Over the course of the glaucoma laser trial follow-up study, eyes treated with initially with ALT had lower IOP, better visual fields and optic disc status than their fellow eyes treated initially with topical medication. As compared to eyes initially treated with medication, eyes initially treated with laser trabeculoplasty had 1.2 millimeter greater reduction in IOP, which was statistically significant, and a greater improvement in their visual fields. The overall difference between eyes with regard to change in ratio of optic cup area and optic disc area was also statistically significant, which indicated slight more deterioration in eyes treated with medication. So the conclusion from the laser trial was that initial treatment with ALT was at least as efficacious as initial treatment with drops. In 1995, Latina and Park introduced the selective laser trabeculoplasty, which used a 532 Q-switch double frequency YAG laser, which prevents heat dissipation in the trabecular meshwork, reducing collateral damage, and was FDA approved in 2001. SLT is thought to reduce the IOP by increasing aqueous outflow throughout the trabecular meshwork. This is one of the first study on SLT and SLT as compared to prostaglandin analogs. This was a study done here in Canada. Over 100 eyes, patients were randomized to SLT and prostaglandin analogs. And what we see in this study is that SLT was found to be equally efficacious to prostaglandin analog in reducing IOP in newly diagnosed open-angle glaucoma and ocular hypertension patients. NSAID therapy had similar efficacy to steroids after laser therapy. And again, this study supports the consideration of SLT as the first-line treatment for newly diagnosed glaucoma patients. So now we have the LIGHT trial, which is the selective laser trabeculoplasty versus eye drops for first-line treatment of ocular hypertension and glaucoma. And it is a multi-center randomized control trial. There's a change in the glaucoma treatment paradigm these days. The paradigm is shifted toward earlier intervention. The term is coined interventional glaucoma, where we're trying to reduce medication burden and solving the compromised compliance issue. The LIGHT study, designed to question a change in clinical practice for the use of SLT versus drops for the treatment of ocular hypertension and open-angle glaucoma. It was a prospective randomized control multi-center trial spanning 6 glaucoma clinics in the UK over initially 3, but now 6 years from 2012. The study hypothesis was, would SLT as primary treatment for lowering intraocular pressure provide a better health-related quality of life, lower cost of care, and improve treatment tolerability with less needs of medication. Inclusion criteria were newly diagnosed open-angle glaucoma and ocular hypertension patients, treatment-naive patients, patients age 18 or older, capable of reading and understanding English. Primary outcomes were health-related quality of life at 36 months. Secondary outcome measures were glaucoma treatment related to quality of life, clinical effectiveness, number of visits at target, number of escalations, and healthcare resource use. So what we've seen is that SLT provides superior IOP stability to drops at a lower cost. 3/4 of patients successfully controlled without drops at 3 years. Both groups had similar endpoints in terms of IOP, visual acuity, and visual field loss. And the secondary outcomes suggested a better health-related quality of life outcomes for the SLT group. There were more ophthalmic drop-related adverse events reported in the patients with eye drops compared to the selective laser trabeculoplasty. And what we can see is that SLT first offers a better IOP control, more visits at target over 3 years, less treatment escalations, less disease progression, less intense drop therapy, no glaucoma surgery, and less cataract surgery. This is the first study that reports disease control without topical medication provided by primary selective laser trabeculoplasty, and does so with a realistic but stringent target for IOP and objective escalation criteria. So what we see from the LIGHT trial is that no systemic adverse events from selective laser trabeculoplasty. There was one SLT resulting in an IOP spike requiring therapy. So 1 out of 776, that's pretty major. SLT as the first line overall cheaper than drops. So for every patient given SLT first, instead of eye drops, the cost savings are greater than the cost of SLT for 2 additional patients, or equal to the cost of 5 additional ophthalmology specialist appointments. So the study design makes results applicable to daily life. Target pressure, consider disease progression and treatment escalation, strict decision-making protocol, fixed follow-up appointments. So the conclusions of the LIGHT trial is that primary SLT is a cost-effective alternative to drops that can be offered to patients for open-angle glaucoma and ocular hypertension needing treatment to lower intraocular pressure. So the interpretation of the study is basically that selective laser trabeculoplasty should be offered as a first-line treatment for open-angle glaucoma and ocular hypertension, supporting a change in the clinical practice. So what I do with SLT, and that's kind of the procedure itself. So pre-laser, naturally, we have to consent patients for surgery or for the laser. I specifically do not call it surgery. It is a procedure for me. Pre-treat patients with iopidine or alpha-GAN, and consider IOP spikes early in your treatment experience, but also if you're concerned of a pressure spike. These are the parameters I use. I always start with around 1 millijoules. it depends. I do between 50 to 100 spots, depending if I do half an angle or the entire angle, so 180 degrees or 360. And our target tissue reaction or interaction should be champagne bubbles, as we see in the video below. When we talk about subthreshold pulse laser trabeculoplasty, same pre-laser procedure, consent the patient, pre-treat with an alpha agonist, consider 1 hour IOP, and these are the parameters that I use. The type of laser you use, whether it's a green, yellow, or red wavelength, do not matter. I use a 300 micron spot size, and you see if we compare the two videos, you can see that this SPLT laser, the spot size is smaller, so maybe also compatible with slightly narrower angles. These are the parameters that I use, and I have to do about 120 applications over 360 degrees, because otherwise I feel that we don't get a decent response. In terms of post-laser therapy, I, again, depend on my concern of an IOP spike after the laser. I sometimes do perform a 1 hour IOP check. In the past, I used to give non-steroidal anti-inflammatory drops to patients receiving either selective laser trabeculoplasty or the subthreshold pulse laser trabeculoplasty. I now give no anti-inflammatory drops after the laser, and I typically see patients 4 to 6 weeks after laser to gauge the initial effect of the therapy. So what is exactly subthreshold laser trabeculoplasty or subthreshold pulse laser trabeculoplasty? So SPLT is a laser delivery modality that allows fine control of the laser energy delivered. It takes the continuous wave laser emission and chops it into short pulses of energy. These short pulses allow the on time, which is the energy delivered, and off time, which is the interval between the pulses. This off time allows the tissue to cool down and prevent collateral tissue damage. So now I'll present a couple of papers that compare SLT to SPLT. So this is a study out of the US comparing SLT versus micropulse laser trabeculoplasty, which is also called SPLT in open angle glaucoma. Over almost a year's worth of study, this figure shows that a decrease in IOP was similar in both groups receiving the micropulse or subthreshold laser versus selective laser trabeculoplasty. And when we look at percentage of decrease in IOP, as well, the percentages were similar at 52 years with no statistical significance. So this study concluded that micropulse or subthreshold laser trabeculoplasty is a novel therapy in the treatment of open angle glaucoma. The results from this head-to-head comparison of selective laser trabeculoplasty to the micropulse or subthreshold laser provide evidence that MLT or subthreshold laser trabeculoplasty is similar to SLT over 52 weeks. This is another study out of Latin America, again comparing MLT or micropulse selective laser trabeculoplasty to selective laser trabeculoplasty. They randomized 67 eyes. This is a study which used the LIGHTMED laser for both modalities. And what we can see here at 3 months is that IOP reduction in both the selective laser trabeculoplasty group and the micropulse or subthreshold laser trabeculoplasty group were similar, with statistical significant improvement in IOPs. Number of eyes in reducing percentage of reduction were also the same in each group. So who is our ideal first patient for laser trabeculoplasty? So it would be typically a middle-aged woman or man, nicely open Schaefer grade 3 or 4 angles, having a little bit of pigment in their trabecular meshwork for us to be able to see our target tissue, having ocular hypertension or open angle glaucoma. Let this be their first line of therapy, and potentially mild field loss, and someone that is not keen on daily drop regimen, or someone that's saying, I know I will not be putting in my drops regularly. So the LIGHT trial showed us that laser trabeculoplasty is superior to drops on compliance. It showed us visual field stability, better health economics. It is repeatable. There was no patient factor in the treatment, so it didn't rely on the patient to use drops. No need for post-op drops. And there was no concern for IOP spikes, no need to stick around in clinic for another pressure check, and less overall office visits. So in conclusion, SLT or laser trabeculoplasty in general is a safer approach with lower percentage of IOP spikes. The IOP lowering is comparable in all other laser trabeculoplasty modalities. No anti-inflammatory drops are required. One machine in this laser modality fits all offices. So as we said, this laser offers both an SLT option, but the subthreshold pulse laser trabeculoplasty is actually generated with a 532 green laser, which means it is also capable of performing retinal laser. And that's why it is one machine fits all offices. And it allows us to perform also YAG laser, the SLT selective laser, the subthreshold pulse laser trabeculoplasty, 532 green laser, but I also perform a subthreshold focal or grid laser for macular pathologies. So really an all-in-one brilliant device. And we kind of initially started in saying superior optics. So we'll just move on a little bit to angle closure. So when we talk about angle closure glaucoma, we know that the ocular hypertension treatment study taught us that lensectomy reduces IOP, but that is open angle or ocular hypertension. Let's not confuse ocular hypertension with angle closure. And I say this with great respect to the lens, to the angle, and the optic nerve. So in a healthy individual, we may see a 1 to 2 millimeter reduction in IOP with lensectomy. Lasting duration of reduction is very variable. And we know that in pseudo-X, we can see higher rates of IOP reduction. Back to angle closure glaucoma, 30% of primary angle closure patients might progress to frank open angle glaucoma, to primary angle closure glaucoma over 5 years. An acute attack of angle closure happens in about under 3% of patients with primary angle closure per year, and 20 to about 60% of patients with primary angle closure who undergo laser peripheral iridotomy might develop peripheral anterior synechia, may still develop glaucoma. So this EAGLE trial, which is basically effectivity or effectiveness of early lens extraction for the treatment of primary angle closure, was a randomized control trial done in UK and East Asia. Basically, patients with new primary angle closure, glaucoma or primary angle closure with elevated IOPs above the age of 50 were divided into two groups: patients having a lensectomy, basically cataract surgery, and patients having laser peripheral iridotomy, and the sample size was pretty sizable. There is no uniform treatment for all cases. Many factors influence our decision-making when it comes to angle closure: age, disease severity, target IOP, medication tolerance, and compliance, of course. And according to mounting evidence, lensectomy should be considered in every angle closure case. So if you have a patient that has primary angle closure glaucoma and has a cataract, you can consider performing lensectomy. If you have a primary angle closure patient with clear lens, that is a tough decision. Depending on their refractive error, if they're hyperopes, they may actually benefit from the lensectomy. Trabeculectomy in these cases has more complications than lensectomy. And the interpretation of the study was that clear lens extraction showed greater efficacy and was more cost-effective than laser peripheral iridotomy, and should be considered as an option for first-line treatment. Younger patients with controlled narrow angles that continue to shallow, one should consider a laser peripheral iridotomy. So let's see our first narrow angle case. So this is a 70-year-old white male that was referred to me initially for decreased visual acuity in his right eye with subretinal fluid. In the differential, it was either wet AMD versus a papillomacular bundle branch vein occlusion versus an old CSCR. We started intravitreal injections that actually went on for 3 years in the treat and extend protocol. IOPs were always borderline in the 20s, but also the patient was a little squeezing every time we checked his pressures. Central corneal thicknesses were on the higher end or on the thicker end. However, visual field and OCTs, ganglion cells, were normal, but angles were very tight, just like his eye fissures when we were checking his eye pressure. So at some point when pressure started creeping up, and we can see his ocular parameters or biometric parameters on the left, his anterior chamber depth seen on the anterior segment of this anterior optical biometry were on the narrow or on the shallower side. I decided to actually perform cataract surgery, and we can see the anterior segment OCTs on top and then on the bottom, and we see that the angle profile from a pupil block kind of went into a more flatter and a more open drainage system. The next case is a 49-year-old white female, which is kind of maybe more of the typical profile for narrow angles. Referred for narrow angle, Schaeffer's were pretty narrow, under 20 degrees with Schaeffer 1. Questionable family history of glaucoma. The visual acuity was perfect with a hyperopic correction. Intraocular pressure, visual field, and ganglion cell complex on OCT were normal. Anterior segment OCT and gonioscopy definitely showed narrowing of the angle with some iridotrabecular touch in some areas. So she was kind of either primary angle closure suspect. After discussing the risk benefits alternatives and 5-year progression to either primary angle closure or glaucoma, she consented and we went ahead with bilateral simultaneous laser peripheral iridotomy because this was definitely a lower risk patient. And again, look at the superior optics. One application of 4.0 millijoules of energy is all that is needed in in some cases. And we can see pigment, and we can see the kind of mushroom aqueous egress from the sulcus. So case presentation, 87-year-old white female being followed for advanced open-angle glaucoma. Best corrected visual acuity 2025, had cataract surgery years ago. IOP in the right eye was trending up, 18 on a combination beta blocker alpha agonist combination. Very advanced disease with, we'll see the visual fields shortly. Was not keen on filtration surgery and said that visual acuity is still good. She's heard about this cold laser and saw a video with the champagne bubbles and was keen to try it. So these are her fundus images. We can definitely agree that there are very, very significant cupping. On her OCT, we can see both very thin total thickness RNFL and very thin ganglion cell layer complexes. And these are her visual fields. We can see superior altitudinal defects and inferior arcs in both eyes that seem to be progressing. So we proceeded to go ahead with SLT procedure in both eyes. I titrated the energy a little on the lower end, didn't do a full 100 applications just for risk of IOP spike. We did do a 1-hour IOP check, which revealed no spike. And she is now at 12 months out. IOP is in the lower teens, and both patient and doc are happy. So this is another case of a 74-year-old white female being followed for primary open-angle glaucoma, undergone cataract and an angle-based MIGS in both eyes. Visual acuity is 20/20, but IOP is starting to creep up. On the right, advanced disease, and on the left, moderate disease, and was not keen on getting back on drops and wanted laser. Again, fundus images, we can appreciate the very large cupping more on the right than on the left. Very advanced disease on visual field on the right involving 10 degrees of fixation. And again, looking at the OCT with retinal nerve fiber thinning more on the right than on the left. And for this patient, because I was concerned of an IOP spike, and I found with a subthreshold pulse laser trabeculoplasty, one gets absolutely no IOP spikes, I opted to do a subthreshold pulse laser trabeculoplasty rather than selective laser trabeculoplasty. She was pre-treated in the proper manner. We did a full 360-degree treatment. There was no IOP rise after the laser. 6 months out, IOP is definitely on target in the lower teens. And this actually shows us that potentially laser trabeculoplasty can be a good option even after angle-based MIGS. And last case is a 36-year-old white male referred by his sister-in-law, which is actually an optometrist in the area. Had very good vision, elevated IOPs with suspicious cup to disc ratios, very strong family history of glaucoma, great visual acuity, very high intraocular pressures, especially for this young man, kind of thick-ish central corneal thickness. However, his OCTs were normal, visual field still very poor reliability, and was not keen on starting daily drops that might also change his appearance if we start with a prostaglandin analog. So we actually proceeded with a consecutive bilateral subthreshold pulse laser trabeculoplasty 1 week apart. The reason I didn't do both eyes is because, again, younger patients, I am more concerned of an IOP spike. So I did one eye at a time, went with the subthreshold pulse laser trabeculoplasty. He did get an IOP check at 1 hour, which was revealed no IOP elevation. And pressures were down to 22 and 18, which was initially good for now. And considering his age, family history, we kind of both know, and we've talked about it, that he might need more therapy in the future. So that is it for my talk. These are just some YAG, very impressive YAG capsulotomies and views from our beautiful LIGHTMED laser. And I'm be very happy to entertain any questions.
Thank you, Dr. Shoham-Hazon. That was great. So it looks like we did take up an hour, and because there were a couple questions pre-addressed, I know that you mentioned or that somebody had asked what are the differences between using the 532, 577, and 810. And you mentioned that there were no differences in the protocol.
Exactly. So exactly, I can try and go to the slide. So the parameters used are very different, are very similar in all the treatment of the various wavelengths. So I have reviewed the literature. Sorry, there we go. So these are the parameters I use, but it should be the same parameters in either the 532, the 577, or the 810. And it works just the same. So if we look at the spot size, we utilize a 300 micron spot size. In terms of duration, it's 0.3 milliseconds. The duty cycle is 15% duty cycle, and you start off with 1,000 milliwatts of energy, and you do have to apply 120 spots, which means that they will be overlapping quite a lot to get 360 degrees of the angle. I know I've heard some doctors start increasing the power a little bit if they don't see any tissue or target tissue interaction. So they might want to see not so much of a blanching, but some kind of reaction from the trabecular meshwork. Because definitely when we do selective laser trabeculoplasty, we do see the trabecular meshwork sometimes move, but we definitely see champagne bubbles. When you do subthreshold pulse laser trabeculoplasty, you don't really see any tissue interaction. So I've you know, if you reach a certain comfort level where you feel you want to titrate the energy up a little bit, I've heard that has been done as well.
Okay, perfect. Thank you. And while we're on this slide, actually, could you emphasize one more time, when is the situation between when you choose between using SPLT or the SLT as your first approach for a patient?
So if it basically to me boils down to, am I concerned that they're going to get an IOP spike? Or am I absolutely confident that I'm not risking any pressure spike after laser? If there's any doubt in my mind, I would opt for subthreshold pulse laser trabeculoplasty. I find that SPLT may be a little more forgiving in terms of pressure spikes. It's kind of, if we want to call it the softer laser of the two. So if you are concerned whether it's a starting off with higher pressures, whether there's a lot of pigment in trabecular meshwork, or if it's a younger patient, the subthreshold pulse laser trabeculoplasty may be a safer approach. Not to say that selective laser trabeculoplasty is not. We have seen the LIGHT trial that 1 out of 700 had an IOP spike. So that's a tremendous comfort in safety profile for laser trabeculoplasty in general. So that's kind of how I go. Something that we've always also done in my center is if we want to start with a safer approach, which is a subthreshold pulse laser trabeculoplasty, and we don't get the oomph that we need in terms of pressure lowering, you can always do SLT after. So they're almost interchangeable and repeatable, and you can do one and then go on to do the second one. So you're not committed to doing just one type or one modality.
Okay, great. That's super helpful. Um, okay, well, that's it for today. I really appreciate you going in depth into each procedure. And as I mentioned to our audience, we have this session recorded. I do plan on constructing some written collateral for a lot of these cases that you've presented and some background information, as well as your approach and protocol that we are going to work on and releasing next year. So I look forward to working with you again very soon. Thank you so much for your time today.
Thanks a lot. Thanks, Jennifer and LIGHTMED, and have a great weekend, everyone.
Thank you.